Thank you very much. Welcome everyone to this meeting in public of Sussex Partnership NHS Foundation Trust. My name is Peter Molyneux and I am the chair of the board. I would like to welcome specifically Paul Colburn today. Welcome. You're standing in for Gurpreet, who's on leave at the moment, and Jackie Buckley will be joining us later on. I don't have any apologies for absence other than Gurpreet's apologies. In terms of declarations of interest, I need to add that I'm now a board member of NHS Providers, and so I need to add that to my declarations. I've also just joined an expert advisory group on the future of universal support for the DWP, and I need to add that to my declarations today. Can I move to the minutes of the Board of Directors held on the 7th of June? I think we had a slight misstep with these. I signed them off, but I think I might have signed off the wrong version. So there's more typos in here than I would normally hope I let through. So I'm very sorry, and I want to apologise to the board for that. What I suggest is, if it's okay, so we just go through and sort those out. I don't believe that very many of them are material, but there are some things that we just need to correct and change. And there is one place where we were reporting what someone who was doing the patient's story said. But if we don't make that clear in the minutes, then it looks like we're saying it. So if it's okay with the board, we'll just sort those out and then we'll circulate them rather than going through them now. And I do apologise. I think that something got lost in translation, and I take full responsibility for that. But that'd be all right with everyone. I don't believe they're material. I don't believe they're material as such, but there are just some things where we just need to be a little bit careful. We haven't had any. So can I then take the minutes for accuracy? It appears that I can. Thank you very much. I haven't had any questions from members of the public. In terms of the chair's report, I'll take that as read. There are a couple of there were several items of business within that I do just need to draw to the board's attention. You have the annual review of the board performance of the board, which we need to note. We have the annual review of the Appointments and Remuneration Committee, and I'm seeking approval of the revised terms of reference. So can they be approved? It appears that they can. Thank you very much. We also just need to note that we have gone, because we had 2 departures from the board that we weren't expecting to happen at that point. We're not currently compliant in terms of the number of non-exec directors as opposed to the number of executive directors. So we just need to note that. We don't believe that this is affecting our ability to carry out our business, and we do have plans in place. One, we are actively seeking a nomination from our university partner to replace Professor Llewellyn, and that's in hand. And we are out to advert for a replacement for Amanda Jones's role. So I am expecting us to come back into compliance in short order. However, I am confident we can exercise our business effectively, and we just need to minute to that effect. Hopefully people are happy with that as the current situation, well, understand that as the current situation. I don't have anything else to say on the chair's report unless there are any questions. Dinesh.
Just a correction. In the minutes of your report, it says Rachel Goldsworth. Is it Rachel Goldsworthy or Goldsworth? I just want to make sure that we've got the spellings of her name right.
Goldsworthy.
So we need to add a Y to that then. Thank you. We
do. Okay, thank you very much. And thank you for showing that you actually read it. Can we move on to the Chief Exec's report, please?
Thank you very much, Peter. I don't plan to go through the whole report because it's quite meaty due to there being a lot of publications that have come out, and but I'm happy to talk about them if people want to. But I thought I'd draw out the highlights, and you'll see that amongst those papers are the NHS mandate, the workforce plan, the EDI improvement plan, and I would encourage you all to have a good look at them because I think they give a good sense of the direction of the NHS, the culture that's being developed in the progressed in the NHS, and the priorities for the year ahead of us. The industrial action, as you'll be well aware, has continued, and the Trust has managed this effectively, but I don't think we can underestimate the impact that that will have financially and on operational services. So having to pay for people to cover for strikes and for also where clinics have been cancelled. So we managed to run emergency services and a Christmas Day level service, but it will have an impact on performance and on financial position. The shared delivery plan for the system has been approved, and it is in your appendix of the report. It's quite, I think it's a really exciting report. It really signals us working together as an ICS across partners, and it sets out some key priorities and what the outcomes will be for that we're all working towards. And it's heartening, I think, to see that there's the newly formed Mental Health, Learning Disability and Autism Board, which was formerly just the Mental Health Board, and then Learning Disability was separate. Autism went across the Learning Disability and Autism Board, but also there was another board, and it's all been brought into one board that I chair on behalf of the ICS, and is really well attended. So we had our first full board recently, and 25 people came to that from across partners, both voluntary sector, statutory sector, and we have since decided that we're going to invite the police to that as well, so we can also really have embedded the right place, right RCRP, right care, right place thing that's happening at the moment. And then what's also heartening is that it's really explicit that mental health and learning disability and autism is, there's an expectation that it is considered across all the work streams. So we have representation in all of the work streams, and therefore we can make sure the voice of mental health, learning disability and autism is heard. A highlight from the period since we last met was the launch of our mental health innovation programme in the urgent and emergency care pathway. And it started with a week that coincided with the birthday of the NHS, and we ran it in Brighton and Hove. We're taking the learning from that, the learning from the PSC review into the urgent pathway, our business as usual, and some work we're doing around people who are long stay waiters in the emergency department into a system-wide urgent emergency care pathway improvement plan that I'm leading on behalf of the ICS. And the focus is on improving the experience of people with learning, with mental health problems who are in crisis, and making sure they're getting the safest care in the most appropriate place possible. And we're already, I think, particularly from the Innovation Week, showing that we're seeing the signs of the benefits of working together on this as partners, sharing the risks, and thinking about innovation spaces for people to think differently together rather than in their own organisations. I want to end with a couple of pieces of positive news, and one is linked to the action log. That on the action log there was a matter that was amber, and that was for Dan to bring back a recovery trajectory around the complaints. That hasn't been done because we have cleared the backlog of complaints early ahead of trajectory, so we have no overdue complaints there now, so that we wouldn't be able to provide a trajectory that sits at zero. We're just going to maintain that as zero. So we've maintained that since the 21st of July and have no overdue responses. And I want to formally, as a board, thank the PALS and complaints team and the operational services for really getting behind the drive. We did 2 weeks, really significant drive on this to just clear them, and now the team's feedback is we can be more forward thinking and we can be more proactive because we've cleared that weight that was on our shoulders. That's really positive. The other final thing, that positive piece of news, is that we have appointed our new company secretary, and David Triggs, who will be joining us shortly. And once Rachel Goldsworthy starts on the 21st of August, and then David Triggs starts, we will be at full complement, which is really exciting. So I'm open to any questions.
Any questions for the Chief Executive? Joe.
Thank you, Jane. Just a couple of questions. One is in relation to the shared SDP and financial support for that. I noticed in your report that you said that by September, this financial strategy will be available. And I wondered if you could say more on that in relation to one, whether it is you envisage or there is evidence that there will be more money available through that route to support mental health and learning disability and neurodiverse issues. And secondly, if there isn't, what other resources will be available? And then my other question was in relation to complaints. I think it's absolutely terrific news, and I've banged on for such a long time about it when I was chairing the Mental Health Act Committee. But it would be, I would find it informative to see a breakdown of the complaints. I know the Mental Health Act Committee used to get it, and it probably goes to Quality Committee. But what are the main themes of those complaints?
Yeah.
And in terms of inequalities in health, who's affected and what actions are we taking?
Yeah.
And the impact of that. Thanks.
So in relation to the first question, maybe I could start and then with Usman, you might be able to pick up. I think we can safely say there is no new money. We're absolutely clear there's no new money in the system, but it's about doing things differently. And I know that sounds a bit trite and a bit like something everyone says, but what we're saying is that we have SROs that are the chief executives of provider organisations on each of the 11 work streams. And then we as chief executives meet informally once a week and formally once a week. And we use our levers and think about the priorities of the whole system so that we're targeting our resources in the right place and we're sharing risks. But the rest of the conversation about September, I think Usman would be best placed to answer that.
Usman.
Apologies, sorry, I'm struggling with my AirPods here. So can I just double check, was that the question about the plan, the financial plan for October?
Yeah. Have you got that?
Yeah, sorry. We're currently, we met all the chief financial officers met in the system on Friday. We're currently drafting what we can talk about as the medium-term financial strategy document. And once that's it's going internally, it's been doing some work. Once that's agreed amongst us, we'll then share that with all the relevant organizations and partners and then seek to commence that work. I think the important thing is we were all very clear that for this to be meaningful, it's not going to finish by October. We will have made the first draft of this with a clear set of assumptions by that point, and then we will use the course of the rest of the year and as we go through planning around to make sure they're all tied up and actually then develop what those plans look like. Because I think, without dwelling on it too long, it's relatively easy to create a desktop medium-term financial plan that just is on an Excel spreadsheet and says this is your gap. What we all recognized was the challenge of how we're going to close the gap, which there will be. As Jane said, there is no new money. This is about how we reuse our resources, about what our transformation programs should result in. All of that will need to be worked up in detail, and then we'll take the outcomes, all of that will then form a final version of that financial strategy that will come later on in the year.
Yeah. So I think, Joe, when we think about complaints, obviously complaints come through to Quality Committee, and then we do get a thematic analysis of complaints. Are you saying it's about making sure we understand who are there other people? Is there disproportionate representation of different groups within the group of complaints?
Yes.
Or do you mean yes? Yeah.
Yes. I think
So it's another layer of analysis. Sorry.
Yeah.
Yeah. So I think we should. I think that would be a good thing to do. Thank you. Where am I? Anna, please.
Thanks, and Joe, thank you for that suggestion, and I'm sure we will be covering that in Quality Committee. So I just had a couple of comments and a question, Jane. Great report. Really pleased to see the Mental Health Innovation Programme. I thought that was, fantastic, and really exciting. On one hand, I thought that your update on the Social Housing Regulation Act was good news, and I suppose I'm hopeful that we will have some sense of whether that new power is actually going to make a difference to vulnerable people and victims of domestic violence. So I don't know how that happens, but it feels like a really important thread, you know, something for us to keep an eye on as that unfolds. And then you've got the other side where on the national picture, you've got this shift away from mental health in the mandate. So on one hand, we've got some good news from national about greater regulatory oversight and possibly intervention, and then perhaps less on the mental health at the national level. But at the local level, it feels to me from your report that lots and lots of things are going on, and there's much more, you know, of a sense of momentum around integration. So all good news. The question I had was around the rapid review and the SIB national investigation. And I just wondered what your thoughts were on how that's going to impact on us, because that feels like a fairly major and high profile piece of work. And, you know, the 4 areas that they're talking about, you know, how providers learn from deaths, young people in inpatient settings, out of area placements, and safer staffing, all the things that we are really keeping a close eye on. But how is the work that we are doing, you know, going to then interact with the investigation? Have you got any sense of that at the moment, or is it too early?
I think it's too early, to be honest, but I do think we know enough from the review and the 5 themes to be mapping where we think we've got evidence and where our weaknesses are, regardless, because it's a good thing to do, and it means we're learning from national. We're not just doing it because regulators are coming in, and I would expect that to go through the integrated safety report into QC, so that you're able to see what the areas of strength, what areas of challenge, and what we're doing about it. But it's too early to know what it's going to look like nationally.
Okay, that's really helpful. Thanks, Jane.
Thanks. Kevin.
Jane, yeah, share what was previously said about being a comprehensive, thorough, and actually really interesting paper. Thank you. And my mind is always drawn upwards to the system and system level, and the systematic review of the challenges faced by our at-risk populations. I was wondering about alignment and conflict within the system plans. I mean, and I guess specifically, you know, are we sorry, can I be heard? Sorry. Yeah, interacting with the system at all the levels to be able to make sure that we are aligned and make sure that we've got enough resource there. And also, while I know there's no new money, and we've been very good at advocating for our part of the system, you know, it does strike me that there are huge opportunities going forward in the ethos and in the spirit of integrated working, where it's not about resources for us, it's resources for the issues, if you like. And if it's an ongoing needs assessment that we are kind of cited on that, and that we're able to sort of sensitively and intelligently feedback to the system where the needs are, and as we're creating community teams or whatever, that actually mental health plays its part and is resourced, if you like. So a very long question about alignment and making sure that our plans are aligned, but also that we do definitely see the opportunities, particularly in the longer term aims of the system.
I'll try and answer what I think you've asked, if that's all right, Kevin. But if I don't get there, let me know. So there are 11 work streams in the shared delivery plan that we've all signed up to, we've all agreed, and it took a lot of effort to get there and a lot of debate. And I think a lot of that effort and debate was part of the work to get us aligned. The process in itself was helpful. And as part of the result of that work, we've got very senior people with mental health and learning disability experience in all of the work streams. And then Colin holds the ring on making sure all of it comes back to us and that we're cited on and feeding into. So it's a two-way thing into all the work streams. And if you look at UEC pathway for mental health in particular, that obviously touches on the UEC work stream, it touches on the mental health work stream, it touches on the people work stream, on the discharge work stream, all the work streams. But as a group of CEOs, we said we'll have it in the Mental Health, Learning Disability and Autism Board, but that the report that goes to that board will be at the other boards for information. So, and then somebody from that board will be on the Mental Health Board as well. So we've got someone from the Acute Trust on our Mental Health, Learning Disability Board. So we've got a sort of metrics of how things feed into each other. And then once a month as chief executives across the system, we have our system oversight board, where we look at the key deliveries for every work stream, where we're not progressing, where we are progressing, and how we can work together to unblock things. So we've got quite a robust system around that at senior level. I think the next layer is on the ground. What does that mean? And I think that bit is we are going along. We've decided on there are 17 places, 3 places and 70. See, I'm even getting 17 localities that are aligned in the 3 East Sussex, West Sussex, and Brighton and Hove. And we're going to form our teams and around that, and then we have to decide where mental health and learning disability fits within that. So that the flow of information, but I think also so that what we decide at senior level has meaningful impact on the ground and is rooted in reality. I think the bit that we are still grappling with as a system, and I certainly was chairing a meeting where we had a paper on it, was the co-production piece and the involvement of the population, service users and carers, and moving from a very transactional, having somebody on a board, to what does meaningful co-production mean and what does that mean for the system. And that's a piece of work that's going ahead.
Really helpful, thanks, Jane. And that was the bit I was getting on to, was the interface between our services on the ground and how we can, and over time that will also speak to the efficiency and effectiveness agenda, because that's part of the benefits integration. Thanks, Jane. Thank you.
Okay, thank you very much. Is there anything else for the chief executive? No. Okay, so thank you for the report. I will resist the temptation to talk about the Supported Housing Regulation Oversight Bill. I'm very happy to do so, as if asked. And then I think we note the improvement on complaints. I think that perhaps, Jane, I mean, you quite understandably, you're reporting on the metric. I think that as someone who sees a lot of the complaints letters, one of the things is we're starting to get to the point and not just the metric. That yes, there is something about timeliness, but there's something about why did people complain in the first place and what were they hoping to achieve when they did that. And it feels that we're managing to get more towards that in some of the ways in which we're now able to engage with people. Obviously, we need to keep noticing the themes that are coming out of complaints, and then, as I think it would be good to overlay onto that some better understanding, but with a more granular use of data around what different communities, what different protected characteristics do complainants come from, and are there themes there that we need to pick out in order to understand some of the issues that people are complaining about. Okay. Joe, were you looking with, did I not summarize that properly? No, it's fine. Okay. So we'll move on from there. So we've got this, so Teresa, we've got the strategic review of the breakthrough objective. Obviously, we've seen quite a lot of the information here as a board in terms of the patient safety incident review framework. And I think that, I suppose what we were hoping today is to get to sort of like, how do we use this as a board? How does it link with our quality improvement work and our quality plan? And how do we ensure a focus on inequalities while we're doing it? So I think that's where we are trying to get to with the conversation. But I'll hand over to you, Teresa.
Thanks ever so much, Peter. So I think the last point there that Jane was making around the importance of co-production is a really good segue into this next section of the agenda. As an organisation, there's a need for us to systematically improve the way that we incorporate lived experience into our thinking, our planning, and the way that we're operationally delivering our services. And that's at the heart of why one of our breakthrough objectives this year is to improve the quality of our services through co-production and patient care and public feedback. The PSERF, and as we heard earlier from our patient story, the PSERF is a great opportunity for us to plan how we will take true learning from incidents, and not solely serious incidents as per the current SI framework, but through learning from incidents. As a NHS provider, we always aim to provide safe and effective care for those people that are using our services, and care that's a positive experience for them and for their friends and family. We know from incidents that evidence has informed us that in a complex healthcare system, things can and do go wrong, no matter how dedicated, compassionate and professional our staff are. And when things go wrong, patients are at risk of harm, and many others are also affected. So as we heard from our patient's story earlier from Sarah, the role of having patient safety partners to support us to address the key objectives that we have as an organisation, but ultimately ensuring that our services are safe, effective and are of good experience to people, feels of absolutely critical importance. We have 3 patient safety partners working with us, Sarah, Indy and Michael, all have very different experiences, which again affords us fantastic opportunity. I take the slides as read. I think there's an opportunity here for us to have a conversation as to how we want to best use the expertise of our patient safety partners and use the expertise of our patient safety specialist and the framework itself to truly inform how we continue to develop our services. So an example, and I think Peter, you might have alluded to it earlier, how do we use our patient safety partners to support us through the quality committee? And also through our new subcommittee of the Quality and Risk Management Committee to be able to support us to ensure that the actions that we are taking, the transformations that we plan to make, will truly improve the safety experience and effectiveness for those that are using our services. We have an ambitious plan. We will be working live to the patient safety incident response framework this autumn, as Sarah spoke of earlier. But I'm happy to pause there, Peter, and to open that up for conversation.
Okay, so I think there's 2 bits, is there? There's the bit about, well, how do they feed into our quality system and our governance processes? I'm always nervous to talk about the governance of quality, but you know, there's governance, and and the way the quality system feeds into that. That's one bit.
Yeah.
So the other bit is actually, who are we co-producing with? And who is included in our co-production and who isn't included in our co-production?
Oh, absolutely. So if we consider incidents as they're happening, co-production will be about involving everybody that's involved in that incident,
the
experts around that incident. So the current SI framework will has, through nobody's fault, has resulted in repeated types of investigations over repeated types of incidents, and often comes up with very similar recommendations. Whereas in the new framework, there's the opportunity to look at this through a system-based lens and to pull in all sorts of people, including our staff, to allow us to ascertain what are the actions that we ought to be taking systematically that helps us to prevent incidents from happening like that again. So everybody has a voice. Patients have a voice, families have a voice, our patient safety partners have a voice, our patient safety specialist has a voice. and many others have a voice, and that's wholly different. So the concept of co-production is wholly different. The PSERV supports the development and maintenance of that effective patient safety incident response system. There are 4 key aims: so compassionate engagement and involvement of those affected, as I said, by patient safety incidents, the application of a range of system-based approaches to enable that, considered and proportionate responses to patient safety incidents, and then the supportive oversight that really focuses on strengthening response system functioning and improvement.
So how will that feed into our quality system?
So through the eyes of quality planning and quality improvement and quality assurance, want to make use of our patient safety partners through all of those lenses. So one of our patient safety partners, for example, is a trained QI coach. So we will want to be working with her really closely as we continue to develop our quality improvement, as an example. I'm looking at Anna as I'm saying this. There's a brilliant opportunity for us to think about our membership for our quality committee, but also so that when you're taking assurance, that we've got assurance through a very broad lens, and the same for the quality and risk management committee. The other point here is around how we are monitoring safety, experience and effectiveness and the metrics. I think there's an opportunity for us to be reviewing together the metrics. So we have a view of safety, experience and effectiveness metrics, but actually if we pull in our patient safety partners to help us to consider those metrics, what other metrics will there be that our patient safety partners, for example, would help us to think through differently? We've started to have a bit of conversation around that through the quality committee, and not just quantitative metrics, but the qualitative metrics. So what is the story that people start to tell us differently about the experience that they have within our services?
And can we overlay, sorry, I'll bring Dan in a second, and can we then overlay whether there are other themes? Because the risk is that you're only looking through, if you're looking through the serious incident lens, the theme becomes the type of incident. There's also the theme of the type of person. There are other themes, and so it's just making sure we can pick up the texture of the learning.
Absolutely.
Okay.
Yeah.
Okay. Dan.
Thank you, Chair. I was just going to amplify Teresa's point, and it relates to our earlier conversation about complaints, because the challenge and the opportunity for us and the need is to triangulate and analyse patient experience data that comes from multiple sources, including incidents and including complaints and other soft sources of intelligence. So that's very much on our radar collectively as an exec team.
Yeah. Anna.
So I just wanted to agree with everything that Teresa said. First off, because I think you put it really well in terms of trying to get to the heart of what's this going to mean for us, and I think we had some discussions, have had some discussions in other places about this, and what came across to me was this is about a culture change. And I suppose so I think there's the kind of nuts and bolts of reporting, assurance, clarifying the metrics, getting those right with input from our patient safety partners. There's all of that, but then the side which I think Sarah talked about so well, which was the glacier melting and the need to actually start talking about this in a different way, because I think there has, inevitably the SI reporting can put people on the defensive, and the whole philosophy here that we're trying to shift towards is actually that we see ourselves as human beings within this, and we recognise, nobody comes to work to do a bad job. Everyone comes to work to do a good job, but things go wrong. And actually what we're trying to do is improve things for the individuals who've been, deeply affected by whatever has happened, but also to change the system to make improvements. So I think the reason this is quite a difficult topic to kind of nail down is because it's not just about the metrics and the reporting and the governance and the accountability. It's about something much bigger than that. And I think Natalie, has helped us to understand that. I think Sarah moved us further forward again, but we've all still got quite a long way to go, and it's got to be something that we socialise within teams, I think, as well as within our governance and our structures and processes. It's something that we need to talk about with teams and link to the work that we're trying to really build up in terms of quality improvement, because they're so interlinked for me.
So, Peter, you're on mute.
That's because I've been coughing, so I was trying to do everyone a favour, and then sorry about that. So, one of the things that boards struggle with is that we're trying to stop always looking in the rearview mirror. We don't really want to spend our whole time knowing where we've been. We want to understand where it is where we need to go. So I think that this gives us that opportunity to get a bit more data, both to know where we've been, but where we've genuinely been, but also actually what people then think might be the next steps, the things that we could do to improve. So there's something about how this would inform our understanding of risk, and how this would then understand our framing of the strategic objectives. And it's that link, isn't it, from the ward to the board and the board back to the service, and making sure we're capturing this data on the way up and then out. Sorry, Teresa.
No, thank you. So we've used the data associated with where we've been to inform our local priorities for our first year against our plan, against our which is our patient safety incident response plan. So when we have analysed data from incidents of the last few years, there are key incidents and types of incidents that then we prioritise in our plan for as we convert to the new framework this autumn. So an example of that would be that fatalities for patients that have been an inpatient or have been discharged within the last 7 days would be subject to a review under the new framework, as would cohorts, for example, of gentlemen between certain ages that have died within that period. So there are key incidents and themes of incidents that will have occurred in the last few years that will inform how we prioritise our planning against PSERF in this following year, in this year coming. And then how we wrap around those incidents as they happen in a very different way than we may have done before. So part of the framework will talk about, and I don't necessarily like the word, but the national word is swarm, that we would swarm to the site of an incident. And what that really means is that we would have a very immediate review. Exactly what's happened right now, and what do we learn immediately right now? And how do we then have an incident management review meeting within 24 hours that brings in all of the experts, including the patient safety partners, to allow us to take further immediate learning within 24 hours. There's a multidisciplinary aspect to this also. Keeping the people affected by incidents, whether those be patients, whether those be patients' families and loved ones, whether those be staff, are absolutely central. So this is looking at incidents through the eyes of thematic learning rather than attributing any blame, for example.
So we need to make sure we've got ways of using this to get assurance, to inform the quality plan and then monitoring the delivery of the quality plan, the framing of the strategic objectives and the framing of the board assurance framework. We need
Absolutely.
to actually show that we've done that on the way. So I'm trying to avoid saying up and down, but you know what I mean.
I do, I do. And I think that, you know, the iterative nature of our learning as we begin to use the framework will be that next year's quality plan, for example, will be absolutely informed by the learning through our adoption of the PSERF this year.
Okay, great. Now I've got Joe and I've got Kevin. Joe.
Yeah, my apologies. I can't seem to get the hand to work. So whatever I do, it's not working. Thank you, Teresa. You started off talking about co-production, the importance of co-production. And this is one of those areas where I think helped me to understand this, because I don't know how the NHS works in this regard. But we have got something like 9,000 members. So if we have 9,000 members and we're stressing the importance of co-production, how do we draw on their views and experience to inform the work that we're doing? And this is something that's new. We can, I presume, define elements of it in whichever way we choose. And it just seems to me that that's an amazing, significant size pool for us to go to. I think also that there is a danger in appointing a number of individuals who, so the safety partners, and then those being the predominant views and input into how we respond and plan accordingly. And again, I think we just need to think very carefully about, yes, there's a central experience, but how do we open that out and bring more people in and make sure that more voices are heard and a greater variety of voices and experience? Because as I read this and after the presentation on July the 19th, I thought, well, how do people whose voices aren't heard make themselves heard in this forum?
Yeah.
And what do we need to be doing more of? And I mean all of us, not just you and the team.
I think it's a really important point, Joe, and I think there is much more for us to do in this space. So if we can sit in the executive committee this morning, we were having a similar conversation, but in relation to how we pull the views of our staff and the staff that we might not ordinarily hear from. So I think the same applies for the people that use our services. So Dan, you and I can take some time together, I'm sure, to really think that through further. And I don't always want to go to the heart of, well, we can talk to people that have complained to us, because what about the people that have had a really good service? And how do we take learning from the good experience that people have had so that we can consciously do more of that thing? So I think there's an awful lot more for us to do in that space.
Yeah. I mean, it would be nice to feel, wouldn't it, as we identified some themes that come out of the PSERF work, that we could then bring in the patient and carer race equality framework and identify different groups who could then come in and help inform the co-production or the LGBTQ plus inclusion framework. You know what I mean? We could have a matrix of different frameworks that we could use to develop texture.
Yes.
Yeah, great. Yeah. Kevin.
Thanks, Chair. Actually, my question would have made more sense if I had immediately asked it after your question, Peter, because
sorry, Kevin.
It was Joe's first. Them's the breaks. Yeah, it goes back to the permafrost actually, and back to it was described as a glacier melting. It felt like permafrost, like the way it was described about. But this is also about culture change. This is also about reducing kind of psychological fears around and increasing openness and encouraging a more inclusive person-centric approach to incidents as and when they happen. So it would to jump on Peter's question was about how we know that it's having an effect, and are we going to be linking it outwards to other things like freedom to speak up, or I can't imagine the other kind of meta ways of knowing that it's affecting culture. And that question would have made sense if I'd asked it immediately after Peter's, but hopefully you can still answer it.
So our patient safety incident response reporting is going up, systematically going up, which I'm really pleased about.
Good. The
number of serious incidents is gradually reducing. So what that tells us is that we're reporting more incidents that we might refer to as lower level incidents that have less harm. And certainly what I'm seeing in some of our services that I've got a closer on at the moment is that we're reporting near misses far better than we have done historically. So that's all really, really positive. The PSERF as a framework itself, by the nature of the design, should allow and encourage people to speak up more than the previous framework may have allowed, just by the nature of how that's delivered and the focus on systemic learning rather than learning about individuals and their practice potentially. Now, of course, I should say that doesn't take away the fact that we're all responsible for our practice, but this focus is particularly on the systems and enablers for patient safety and how we quickly learn from those within this structure. So to the point about psychological safety, I think the new framework far better enables psychological safety by the nature of how the framework is designed. And we're certainly seeing more incidents reported, which is great.
Thank you very much. That's really helpful. Dan.
I think the point you made earlier, Joe, which Joe's reiterated about who are we co-producing with, is so important, particularly in relation to the potential unintended consequence of relying on too small a pool of people. And that's certainly one of the objectives I'm asking our new Director of Engagement and Experience, Christmas Masonza, who joins us in about 6 weeks, to work with Teresa, myself and others on.
Thank you. Any final thoughts or comments on how we use this? Jane, was there anything you wanted to say before I asked Teresa to come back in?
I think that for me, this is really exciting. It speaks to quality improvement. It speaks to co-production, to all the things that we tried to filter through our breakthrough objectives. So I think it will contribute to us delivering our strategy. But what we've got to be mindful of is that we sense check it as we go, that we're doing it in a meaningful way, not a tick box way. And I think that would be really helpful for the NEDs to be our critical friend in that, to make sure that it's a meaningful change and that we're doing something significantly different. And what we heard from the patients, the story earlier, that is a reality throughout, not just with that one individual.
Yeah, thank you. Teresa, what would you like us to do next?
I think what I would like us as a collective to do next is to take every opportunity from the new framework and weave that like a golden thread in everything that we do. And it's very, very easy for me to say that, but it's going to take even more time to think about how we actually plan for that. So that means that PSERF as a framework becomes very live as an enabler through all of our work, through our quality plan, through our transformation programme, through our improvement plan, and through our breakthrough objectives.
Absolutely. Can I thank everyone for a helpful conversation? I think Teresa, you've heard some real enthusiasm to actually knit this into our quality system and our governance structures. I've been in the NHS long enough to remember all sorts of phrases that get used, like just culture or learning culture, and actually I feel this really genuinely feels like it's wanting to be curious, wanting to be investigative, but actually wanting to do that in a constructive way that actually properly engages patients and carers and staff in the development of their own care and their own solutions. I think it does help us to deliver some of the cultural things we want to deliver in terms of psychological safety, and you've heard that come through the conversation. I think there's probably a bit of knitting to do in terms of actually how does it really feed into our quality assurance systems and then our quality plan as we develop that. But certainly we could start to model through the autumn as we start to develop our breakthrough objectives in the autumn, And then when we start to think about our risk appetite and the board assurance framework for next year, we could start to really think about and perhaps practice how we use PSERV to do that, so that we've got some moments as we start to develop this. And it might take a few iterations to get to full maturity, but there's no reason why we couldn't start that now. I think certainly then, I think what you heard is that we just need, I think, to think about how we don't over rely this stuff. What we don't want to do is overload this group of partners. We need to still be being curious in other ways. And so we need to link this across to things like the patients and carer race equality framework, the LGBTQ plus inclusion framework. Think about how we bring other groups into it through co-production. I know that's the intention, but I just think we need to make sure we're doing that in a very deliberate way, so that we're getting different text, we're getting a more textured view. But certainly I think all of us will be very committed to making sure that there's a golden thread of using PSERV to inform quality assurance and quality improvement, which is after all what we're here to do.
Thank you.
Thank you very much for that. That was helpful. Thank you. So thank you, everyone. And perhaps appropriately, we should now move to the Quality Committee report.
Thanks, Peter. So you have a report in a slightly new format. I just want to acknowledge Veronica for all the work that she's been doing on this. You've got 5 appendices, 3 annual reports, one on the health and safety ICP, and then the Quality Committee annual report, and then a 6 monthly report on safer staffing, and then a Q4 report on learning from death. So I think what I just wanted to add by way of commentary is that I think, the committee restructure continues. It's work in progress. I think we're still seeking greater clarity on metrics, especially on effectiveness and outcomes. I think we're still working through how the exception reporting model from committees to QC will work, and we're keeping a kind of close eye on that. And I think we've certainly got a kind of desire to maintain a sort of clear focus on our Quality Committee risks and risk mitigation. So, there are 2 main ones as outlined in the report, and a lot of our discussions are around those, albeit coming from different places. So I think just sort of formally note assurance on IPC that in the annual report that's in line with our legal requirements, and we're looking for board's approval on this. And to note the conversation and the work that's ongoing around learning from deaths. I think we really moved forward in our sort of articulation of the need to think about a population-based approach on mortality. Given that numbers remain pretty static, and this means looking more closely at what more we can do to improve physical health, for example, but also to give a more system-wide approach to intelligence gathering and action. Just finally, just to note the swift response on CQC's inspection and the need for system-wide review on incident reporting, which came through from Jane's report as well. So, and I just wanted to thank the governors, I think, who really helped all of us to think a little differently about the quality report and how we could make it more accessible in terms of content and format. So just wanted to acknowledge their input, which we then took forward through Quality Committee the next day. So that's all from me. Any questions or comments, welcome from the board.
Okay, so are there any, I have a a question around the appendices. Were there any comments on the report? Okay. So can I just ask around the health and safety annual report, please? It may just be the way it was written, but I was a little bit concerned that there was quite a lot of process assurance there, but not quite so much content assurance. And there was something around the fact that we outsource some of our work on health and safety. And of course, we can delegate the task, but we can't delegate the responsibility. And it wasn't quite clear to me whether then where the assurance was coming from. Now, I realize that I'm just a layperson looking at a report, so I'm very happy to hear that it's there, but I just couldn't quite pick it up from the report itself. So you know, we have a contractor, but do we know that they're being effective, for example?
Okay.
Please, do you want to?
Yeah, absolutely. I'm very happy to take that. So, Peter, I will take that away.
Okay.
I will take that away and have a look at that.
Thank you.
Okay.
And then, was there anything else on the IPC annual report or the learning from deaths or safer staffing? Joe, did you want Joe?
It's worked.
It's a lovely hand.
Yeah. There was a question about the working alone devices. Yeah. Because reading the report in terms of who's trained and the usage of it, it still seems to be very low. And I know that, was it coming out of COVID, the Health Service Journal that picked this up in relation to our trust and was very critical of the fact that we'd spent a lot of money and weren't using this. And it's not entirely clear from the report why the take-up is as low as it is, and also that the fact that some of them seem to be defective.
So my understanding is that it's a practice issue and there's a cultural issue within that. John, I don't know if I can come to you on this if you have more information on the lone working devices.
We're on page 12 of the report of the Health and Safety Annual Report, if anybody's wondering where we are.
Thank you, Teresa. Thank you, Anna. Just check you can hear me okay?
Yes, thank you.
Yeah, grand, thanks, Peter. I don't have any specific information, I'm afraid, Teresa. I'm very happy again, equally like you, to take away an action and update the board appropriately.
All right, thank you.
I mean, I mean, Joe, it's interesting, isn't it? The HSJ, I mean, we don't know what happens elsewhere, do we?
No.
We don't know what, you know, in other words, are we an outlier?
Yeah.
And what are the reasons elsewhere? I think that would be worth exploring as well.
Yeah, and also if you're going to look into it, what is the contract and how much are we paying for it? Because if the cost benefit analysis says that in fact it's meant to do good and protect our staff, but a lot of them are not using it, then I don't want to get into operational, but it raises questions about usage and value.
Yeah,
good point. Absolutely.
Jane.
Thank you. So I can't answer the question in relation to this trust, but I've done a big piece of work in a previous trust on this, and where usage was very low and we spent a lot of money. And there were lots of issues to do with, well, if you're working in a clinic all day, that's a fifth of your time not using it anyway, that you wouldn't expect to use it. So the usage rate was about 20%. It's not 100%. So, but I think for here, I think there's a piece of work for us to do as a new executive that weren't here when this came to light last time, of doing a baseline, finding out where we are, and then putting an improvement plan in place and reporting it through the integrated safety or the health and safety report, so that we've got full sight of it.
I think that would be helpful. John, did you want to come back in?
I did, if that's okay, Peter.
Yeah.
It reminded me, having this discussion, that it is one of the things included in one of the next rounds of the internal audit. I met with our SM recently. They were asking in their site visits to where they could go and review our processes around lone working, and we have included both, well, I suggested some community teams and some inpatient environments across the trust. So we can add that to the action that Jane's already described.
Okay, thank you. And if I may, can I just ask, I think with things like some of our data, again, there's this thing about how difficult would it be to then overlay an inequalities lens onto some of this, that we don't always know whether this is falling disproportionately on different groups. It may be that the data is there. I suspect it is there, but it's just something about making sure, and I'll say it again, I'm afraid, when we get to integrated performance, it's something like we know how this affects the whole of our population, but are we absolutely confident we know where there's a disproportionate impact, and then do we have the right actions in place? And I think there's just something about making sure we're just checking at each stage whether this is falling disproportionately onto particular parts of the population, and have we then got the right actions. But I don't want to create an industry, but I do think where we've got that, it would be really helpful to pull that through, and it would just add to our understanding, and it kind of talks to the golden thread that you want us to pull through for you, Teresa. Anna.
So Peter, I'm just interested to know whether you've got examples of best practice from elsewhere on this.
If only I had, Anna. If only I had.
Because it's not because clearly that should be what we do, but it's the how do we do it, and how do we do it well, that's more challenging, I think. So I was just wondering whether you had in your mind other places where perhaps they had, but.
So I personally think it would be difficult to know where it's being done well consistently. I know Jane may be about to contradict me, so I'll let Jane come in.
No, I'm not going to contradict you. I was going to say exactly that, and why there's a population health work stream in the ICB that Peter and the team sit on and feed into, and the similar questions you're asking are being asked by the region and the ICB in our quarterly performance review meetings. How do we cut the data in terms of population health and inequalities? So it's a piece of work that Gurpreet's leading on, is getting our data right, because I'd love to be able to say to you that we are able to get it like that, but our baseline data isn't right. So it's not consistently recording all of the protected characteristics. Some of them are, some of them aren't. So there's a whole timeline attached to this about improvement in our data, and then being able to report that we could maybe report to a subcommittee of the board.
So, and I think it's about, if the more engagement we have with the community groups that work with particular communities, that they help us to identify some of the themes, they help us to identify some of the areas where we might want to look and be more curious. And then we have to work with the data we got, because what we don't want to do is create a data industry. But that then helps you to find your lines of inquiry. And that's what I've seen done well. So it just means you're just doing a reality check. And there are some things we've known for years. So there's nothing about, well, how do we shift the dial? So I don't think I've seen anyone do it well. But I think we'd be wrong not to ask the question and see what we can do. I suppose. I've got lots of hands up and I'm still talking, sorry. Jane, is that a legacy hand from you? Yeah, Dinesh.
Thanks very much. I just wanted to go back to the question. I mean, surely that's the kind of thing that the ICBs ought to be doing as to what's going on in their patch and how are left hand and right hand comparing, and then taking into account the basic population data and need measurement, and then titrating what needs to change. I mean, is there any way that we can influence them to start looking at it? Or, I mean,
Well,
could I come quickly there? Sorry.
One of us needs to, Jane.
So they are looking at that, and we've got the 20 plus 5. Call 20 plus 5 work that's going on. So they've done it for each of the 3 places: East Sussex, West Sussex, and Brighton and Hove. and said where the most need is, where the vulnerable communities are. I think it's on us now to understand what our data in terms says, because we know what the population says, and then how that marries against the population data.
Yeah. Okay, thank you. Paul.
Thanks, Peter. Sorry, I was just going to add to the point that Jane's just made. So SPFT are under the shared delivery plan. There are 3 centres of excellence, one around innovation being led by the Communities Trust, one for infrastructure being led by East Sussex, and SPFT are leading the data centre of excellence, and that's looking at the population data of Sussex, and we'll use that within the trust, then augment the data that we're using for the performance reporting, for the analytics and the research that we do. So that's a piece of work that's just forming at the moment. And I think GERPRIT's aim would be then to bring that back to the board at a later stage once it's evolved to a point it's ready to present.
Yeah, and I think Paul and Dinesh and Jane are all making a few very important points about what can we do now, what can we do soon, and what can we do later. But what I don't want to do is get into that traditional thing of, oh, we haven't got data to do anything. We have enough data on some things to do something now, and then we can continue to get better data. And yes, of course, work with our system partners to see if we can get to a much greater level of maturity. Enough of me talking, my apologies. Quality Committee report. Is there anything else on the Quality Committee report for today? I'm conscious there's a few things that I'm going to have to take us through for approval. Okay, so can we please note the Quality Committee report, note approval of the Trust's quality account, which I thought was really good. Nice to see the quality plan now included in that, and that seemed really good. We would like to, can we please accept the Quality Committee's recommendation that we approve the Infection Prevention and Control Annual Report? We can, thank you very much. And we then note that we've asked for further work on the health, further information around the health and safety annual report. And if we can look for where we can provide more granular data in terms of equality of access and equity of outcome, that would be really good to do. But thank you very much for that conversation. And thank you very much for the report. It is about 22:03. Would people like a brief comfort break at this point? Just maybe 5 minutes, get up, move around, and then we'll come back and do the integrated performance report. So could we please come back at 1:45? 1:45? Thank you very much. Good afternoon, everyone. Welcome back. Just to remind ourselves that we're still meeting in public, and to invite us to look at the integrated performance report.
Thank you, Chair. As ever, John and I will do a double act in terms of the performance report. So I'll just take through the key headlines, key messages to note, and then we'll take specific questions on any of the areas that we've identified. I think just to build on what you said prior to the break around looking at this data in a more granular way with the lens of sort of inequalities around it and the specific population groups. I think it's, as Jane said, I think we can definitely find committees to take this to, just to sort of give some reassurance. We've spent the year pretty much significantly improving the actual recording of that data and the collection of that data. I think we're now up to about 93% in terms of compliance around the data maturity index, so where we're actually recording the relevant fields that allows us to get into that space. It's all been part of the data quality improvement plan. And for the majority of metrics that we look at through the IPR, there is data that sits below it that would allow us to get into that kind of analysis. I think it's just, as ever, it's been something that we've worked on over the last year and then been developing. And I think we can agree sort of subsequent to this is that, as Jane said, you know, which are the right subcommittees that potentially that would get a bit, look into that into a bit more detail. So I just start that off here to recognise that at the moment, all the data that you're looking at is at trust level and doesn't break it down further than that. So in terms of the integrated performance report, so this is for the position at the end of June. So I think the key things to sort of highlight within that position is that at the end of June, we were off plan against the 12 core local metrics that we've set ourselves as the areas of focus, against 8 of those targets. And I think we've all recognised through our local divisional quality performance review meetings that isn't an acceptable position. So we tasked all of our divisions to come up with recovery plans for those core areas where we are clearly off target. And so to give some sort of detail behind that, that specifically relates to the areas around, sorry, lost you there for a second, everything froze, against the risk assessment, the care plans in particular. I think one of the things that's come out through the quality performance reviews has been, and it's not actually something that we report on at a trust-wide level, is while we report on serious incidents, we don't necessarily report on total incidents. We have the data, but we don't report on it. And I think one of the things that's been identified is that's something we should add and look into in more detail in the same way that we look at sort of serious incidents, because there is a leading sort of indicator on that sense. So one of the areas that I wanted to highlight as an area that we've been doing significant work on and has actually been quite successful has been around complaints. And I think as the report highlights, as of last week, actually it was, not today, although we've maintained it, we have 0 complaint backlogs, and the response rate has been steadily improving each month from the low point it hit in July of about 37%. And the trajectory to get up to 85% response rate by November is, I think, I don't want to jinx it, on track. The other sort of areas around the IPR, I think it's worth just highlighting, given some of the other things that we've been talking about. We continue to see a sustained and high level of delayed discharges. That metric hasn't really shifted. It has come down from this very, very high point that we saw earlier on in the year at the peak for our winter period, but it still remains high at 18%, and it's over our historical run rate. And I think it leads sort of into the issues around our length of stay. So our length of stay for people over 90 plus days has been increasing, but you can see the correlation to the people who have got delayed discharges. And I think it's just important to draw those links. Partly as a byproduct of those two factors, we therefore have had an increase in the time people are waiting for an inpatient bed. And that has been something we've been working through with our system partners. And I'm sure Peter and John may want to talk about some of the specific work that we are doing at the moment ahead of October in terms of ensuring that we bring that time down. So i.e. the number of time people are waiting both in the ED, but in effect also for an inpatient bed. Against the national core standards, so the things I've been talking about have been largely the 12 areas that we identified locally. Against the core national mental health standards that we've looked at, we are achieving 6 of the standards. And I think in a couple of areas where we are not delivering the national standard, in particular around CYP urgent eating disorders and CYP routine, we have actually shown really significant improvement on those. So from where we were a year ago at a low point of under 50%, for the last 4 months of data that we had, we were almost 80% for the urgent and 90% for the routines. And I think while that is an improvement, we continue to ensure that we are doing the work, putting the focus on it, in particular around the urgents, to get them to 100%. I think recognizing the importance of an urgency of that particular patient cohort. Within the national core standards, I think the one that internally we have been discussing the most and the one that we're putting focus on is around the access target. So the IAPS Talking Therapies access standard that has historically been a challenge for us, in particular in the Brighton area. It remains a challenge for us, and through the divisional quality performance review meetings we've been working with, in particular the Brighton and Hove team, to identify how we are going to get the level of increase we need through the rest of the year to hit our local target, recognizing that we set in agreement with our system partners a target that was less than the national target, recognizing our sort of specific challenges and decisions that we made around use of funds and where we were going to prioritize investment area. Hopefully one of the things that will help is that we have implemented a new system. So our APTA system has been rolled out across the Brighton and Hove teams, and we are hoping that based on the evidence that we've seen of that being implemented in East and in other areas, will result in significant level of productivity improvement, and so that we'll be able to increase access without necessarily having to increase the amount of resource that goes into that area. I think those are probably the key ones I would highlight, and then I'm happy to take some questions on those, or John, if there's any of those areas you particularly want to go into in more detail.
Well, what I suggest is if we take some questions first, and then we can see if John feels that that's needed. Are there any questions for Usman? Dan, or comments?
Thanks, Chair. Yes, comment rather than question. Just on complaints, to say that as well as sustaining our improvement on response times, we're continuing to focus on the quality of our complaint responses in relation to the content and tone of voice. I just wanted to give the board that assurance that we're not just chasing the response time metric.
Yeah, I think that's, and that kind of comes through in the quality of some of the replies that I oversee as well. Anna.
Thanks, Chair. So I just had a question, Usman, on page 6, and I don't know whether this is too specific, but so it felt to me like the risk assessment and care plans percentages. So the specialist teams were the lowest, and I was just curious to know why. I mean, because actually, my understanding is, the specialist teams mostly have a lower caseload. So I'm just wondering what's stopping them getting to the higher percentage. And I'm guessing it varies from team to team.
Others will no doubt come in. I mean, John's got his hand up, and I'll let him come in. I will say one of the things that we've identified through the performance reviews, in particular with specialists, is it covers a broad range. But as we've gone into the divisional model and we talk about the specialist division, it includes everything from our CAM services, LD, neuro, as well as forensics. And I think each of those teams have got some slightly different issues that have come through. So if we go to John, can probably go into it in a bit more detail.
Thank you, John.
Thanks, Usman. Anna, it's exactly as Usman's described, and it's predominantly delays within the neurodevelopmental waiting times because of the volume of ADHD and ASC assessments. That's where we see the challenge. That there are some in the community learning disability teams, and again, that's primarily down to a capacity and demand issue. So it's really about the aggregated data gives you that picture. In terms of clinical risk and safety regarding compliance around risk assessments. So I think it's important just to highlight that this is about the review of risk assessments rather do patients have no risk assessments at all. And it's predominantly people who are, like I said, waiting for neurodevelopmental appointments who've been clinically triaged as a lower risk.
Thank you.
Chair, oh, sorry, Anna.
No, that's really helpful. I had one other question. But,
Okay.
Just about the switch to Power BI, Usman. I mean, is that going to change things in terms of how we see things? So if we're going to safety, experience, and effectiveness, are we going to lose the quality report? The way that at the moment we've got quality 1 and 2. I'm just trying to get a sort of sense so that will allow me to sort of anticipate how we compare what we get now with what we're going to get when we move to Power BI, if you're going to have different headings.
So I think in terms of what gets reported here to the board and what gets reported to the committees, we are largely going to stick to where we've got. So we're not going to lose things. I think for us, the Power BI implementation is more about internally, how do we use information and how do we make it really accessible to our sort of operational clinical teams on the ground, so that they're not having to rely on looking through email to find reports, but they can actually just click through and use it. And I think we've rolled out what we now call the balanced scorecard, which is being used. I'm glad to see the usage is increasing day by day as we sort of communicate that rollout effectively, and that should be followed in a couple of weeks by the online quality and safety dashboards as well, which will go out on Power BI. So that is more about our sort of local sort of operational clinical usage within the divisions, within teams. From a board perspective, I think we'll probably stick with the current format we've got for the IPR, as long as, I mean, the feedback I've had from board members has been that it's been helpful. It provides sort of, for now, it appears the right balance between detail and summary. But that's not to say that we won't keep this under constant review. I mean, the one advantage we have of the way we have set things up and using BI is we can make changes relatively quickly now, and we can amend and update as required.
Thanks very much. That's really helpful. Thank you.
Thank you. John, did I sense you wanted to come in on something else as well?
I was going to, Chair, but
yes, please do, and then I'll go to Nitin and Kevin.
It was really just to draw out a couple more points from some of the other targets that Usman went through, because I think it's important to highlight it. So Usman mentioned the waiting times for people our patients to come into hospital, and I think that is an area that we have seen grow, and we know from contacts that we've made across the country that is a national position, but it is in the context not least of patients increasing, numbers of patients increasing who are medically ready for discharge, but also the numbers of patients that we have assessed as needing to come into hospital have reduced on a monthly basis over recent months because we've been able to find alternatives for them in the urgent care pathway. However, there is a really significant patient experience and safety risk regarding the amount of time that patients are waiting now to come into hospital. And I think it's important just to update or to reiterate to the board the work that Jane described at the beginning in her Chief Exec's report that Peter has been leading, working with particularly with our acute trust colleagues around innovative ways of delivering care to patients who are waiting considerable periods of time to come into hospital, not under the Mental Health Act. And that's really starting to bear some fruit. I think it's just important to touch on waiting times. I mentioned it in the context of the care plans and risk assessments piece, but if you're drawn to the last one of the latter slides in the pack, it's really just to provide some assurance to the board that you'll see that the total number of adults waiting over 52 weeks, which was obviously a board objective for us last year to reduce the numbers of people waiting over 52 weeks, has increased. That is solely related to adults waiting for an ADHD assessment within West Sussex. It is the only area where there is a commission service within the secondary care community teams, the community mental health teams. But I just didn't want people to be concerned that that is a different demand and capacity issue. And I think it's also important to highlight the reduction in 52-week waits for adults with eating disorders. Again, because of the clinical profile of those patients, that's a significant quality indicator as well as a performance one. Those are the only ones I wanted to draw out, Chair, but happy to take any questions from Nitin and Kevin.
Well, let's take a few more contributions, and I might allow myself a question once I've done the other three. Nitin.
Thanks, Chair. This is more a question for Usman and more a clarification. When you talk about agency pay spend, we've got a current percentage of 10.4, target of 3.7, and I think when we looked at the KPMG report at our last F&I committee, it said our budget had a number of 7.7. So just wanted to understand, is the 7.7% what we need to hit our recovery plan, and then the 3.7 taking us beyond that, or is 3.7 what we need to hit our recovery plan? I wasn't sure.
So just great question. I had someone else ask me this yesterday. The 3.7% is the national NHSD target. So that is where they want all trusts nationally to be no more using agency no more than 3.7% of the pay bill. Given where we started the year at almost 14%, we said during planning round it would be unrealistic and unsafe for us to assume that we could do all of that in 1 year. So our plan for this year was the 7.7%. In effect, if we deliver our reductions as set out in the FRP, we'd get to 7.7, and then the following year we'd aim to then get down to the cap level. And at this point in time, based on the first quarter, we have actually gone from 14 down to about just over 10, which I think hopefully will, as we talk about it later, but demonstrates some significant improvement in where we're getting.
Okay. Thank you. Kevin.
Finger on the button, because it's the sequencing of questions. Just to say about the IPR generally, I think we have seen an evolution over time, haven't we? And it's definitely moving from process to approaching something involving outcomes, and moving a little bit from lagging to leading. So it's an evolutionary thing, and I think it's going in the right direction. The question I want to ask, which Anna got to first, was about care plans versus risk assessments and assurance that we were sort of treating them both equally, if you like. One had a SPC data point below, so it seemed to be it was prioritized, and they do go hand in hand, don't they? And so Anna got to that question first, and then John answered it about ADHD assessments in a specialist context. And I was just wondering, if someone's on a waiting list for an ADHD assessment, do they get a risk assessment in a care plan, and how, and would they be counted in those data points? I wasn't aware that was people on waiting lists would have risk assessments and care plans. Was my specific question.
John, do you mind just helping Kevin with that?
No, not still. It's just the microphone button. I think it's waiting in twofold, Kevin. So it's people waiting for core assessments, but it's also waiting for people who've had assessments and may be waiting for treatment. And simply because of the capacity issues within those services, it's people waiting for 6 monthly of annual reviews who are on treatment, and that treatment may have been extended, and that would be the point that their care plan and risk assessment is updated. So it's waits at different points of the pathway that is entirely related to the capacity and demand issues, and in terms of still applying the sort of clinical triage methodology. To your question that I hope I answered, but I'll just push on it slightly. because care plans and risk assessments do go hand in hand, you're absolutely right. Why might you see some slight differences? Because I think you're saying they should be very similar, which is of course correct. Sometimes that is around the recording issue. So we know that we sometimes will have some particular issues, perhaps around the way medical care plans are recorded versus not around risk assessments, or vice versa, because they are captured in letters, and that is some particular work that we're doing to ensure that that is read across into other areas of the clinical record. Hope that covers it.
Yeah, no, it covers it, and I guess my question was more about emphasis, to make sure that just because one had below on this SPC, we weren't suddenly, whereas in fact care plans have come down across 4 data points, not quite to the baseline, to make sure that we were emphasizing both equally, and that is reassuring and genuinely interesting knowledge on how internal care pathways can affect waiting times. I need to learn more. Thank you.
Thanks, Kevin. Joe.
Thank you. 2 questions, one on waiting list. John, can you just remind me what happens, how we're looking after people who are on the waiting list while they're waiting for an appointment or assessment?
Of course, Joe. It'll be different depending on the individual service. So if you're waiting for perhaps a routine assessment within an adult community mental health team, you will have been contacted, you would have received written feedback from your referral, and you would have been given a number of areas or a number of places to contact if your situation changes. If you're in a CAM service, there will be different types of contact, different types of signposting. Similarly, if you're in a neurodevelopmental service, you may be asked to complete various documentation in advance of your assessment. So there are different areas, different clinical responses for different areas. Some will have some services have very clear keeping in touch methodology because of the clinical risk and the level of care and family input. Others will be directing people towards duty systems, community and voluntary sector organisations. There's no one size fits all. We also have rolled out our access policy as part of our waiting times programme, so how we unify our approach to triage, or referrals being received, triage, and our clinical response to that.
Okay, so if I understand you correctly, what we have is process. Do people on the waiting list have a named contact, or is that not something that we provide?
Again, it will be dependent on the specific service, but it's unlikely that we will provide a named contact. It'll be more for a generic contact. So please contact this urgent care service, or please contact the whichever team it is. It's unlikely that it's please contact John or please contact Dan.
Okay, so my final question on this, and perhaps Teresa, you can come in on this, because somewhere in our reports there is a comment about it's the way that we look after people that are on the waiting list that has changed, and I don't quite understand what it is that is being alluded to.
Happy to come in. Yeah,
please.
So, thank you. So in our quality plan this year, one of our objectives is exactly this point, which is about how we address the safety for those people that are waiting for a service from us. And I'm just going to use CAMHS as an example because it's a live one in my mind. So in our CAMHS services, each of the children and families that are waiting for CAMHS receive what is known as a KIT letter, a keeping in touch letter. And they receive that at the point that they're referred in. The format for that letter has been through a number of iterations so that we are assured that the quality of the letter that is going out to the children and their families addresses a number of things, is honest about how long the wait is likely to be, gives clear signposting information around types of services, websites, voluntary sector services, whatever it might be that the person can access. But importantly says, if things deteriorate for you between now and your appointment, this is how you contact us. We are monitoring through the QPR process that process. So one of the subjects of discussion through QPR goes to the very heart of exactly this point, which is And are you confident that you're keeping in touch? Letters are going out, because we did have a backlog some time back, and that's been rectified. So I'm sharing that as an example of CAMS, but it's a key priority for us this year, which is how are we meeting our obligation to keep people safe whilst they're waiting for services, and that's about making sure people know what else is out there for them, but importantly how to contact us if things deteriorate whilst they're waiting.
Thank you. And then can I ask my second question, Chair, which I hope is a brief one. In the IPR, it says that operational divisional performance is below target. And then it also notes that risk assessment, care plans, supervision and appraisals have all been consistently below standard for the last 2 years. And my question is, so what are the actions being taken to address these?
Who wants to take a short question?
I was going to say a nice short answer. I'm happy to start off on this particular point, and I'm sure John and others will have come in. And then if it's all right, I would like just to come back to the previous question Joe raised around how we keep people safe on the waiting list, just because I think that there is an important element of that for us all to be aware of. Joe, I think in terms of the care assessments, risk assessments and care plans, it is absolutely the case that we have hovered performance at a trust-wide position of between about 91 and 92% for the last 2 years, which when it sounds like it's close, but actually has never quite hit the target of 95%. So I think that the answers to that are complicated in different areas. So the CAMS teams, for example, are carrying out more risk assessment and more care plans than they ever have before, but the volume of work they are doing for the number of people they have means that they are unfortunately never able at this point with the capacity we have to achieve that. For our adults teams, while the increase in activity hasn't been as high, you will know from the conversations that we've had sort of through these meetings that the vacancy rates for a number of those teams has been really challenged. And so I think there are justifiable reasons, but that doesn't sort of give us an excuse for why we aren't doing it. And as part of the work through the first 2 quality performance review meetings this year, that is what we have asked the divisions very explicitly, is we've been at this point for the last 2 years. How do we stop talking about why we're below it, and how do we do what in some cases is a small push to get us to 95%? And I think there's always a balance of performance management. People are understandably focused on those areas where we are most significantly off plan. And as John alluded to, a lot of work has happened over the last year in terms of 52+ week waiters and long waiters, the waiting list implementations. And I think at times that means we don't always necessarily focus as much on those where we are sort of close to the target. And I wish I could articulate that in a better way. And what we're trying to shift through the QPRs is those areas where we are close, let's put focus into it and get them above the target so we stop talking about them. And then we can devote our attention and energy from a recovery perspective around those areas where we actually will need to do something quite radically different. So I'm sure others might want to come in on that point. And then if it's all right, Chair, I'll come back on the final point.
Well, why didn't you come back on the final point?
Well, I guess to Joe's sort of very specific question in terms of the wording that we'd used in terms of what had changed, I think Teresa has set out really clearly all the things that we're doing, but the reason it's changed, I think, is important to know because of that increase in activity and our inability, our lack of capacity, in effect, to match that. Those waiting lists have increased. These are problems now that we're having to deal with that we wouldn't have had to deal with 2 or 3 or 4 years ago. And I think one of the challenges that poses is we're having to invest more and more resources into managing people while they're on a waiting list. So as an example, Teresa talked about CAMS. I will get these numbers not quite right, but I think the size of our CAMS duty and liaison service, which in effect is 24-hour service that Teresa referred to as somebody who's waiting, has a crisis and needs to access to it, has more than doubled in size over the last 18 months, partly as a result of our requirement to be able to keep people as safe as we can while not being able to actually sort of hold them in a position to be able to offer them the treatment. And that isn't something unique to us. I think it's important to recognise as well. That's something that in talking to colleagues at other trusts as well, we're all having to deal with. But it is, I think, important to note, because when people look at the numbers and say, well, we've got more people, activity's gone up, but actually because people are waiting, we're having to put new things in place that we wouldn't have had to do before in order to try and keep people safe while they wait. And I think that realistically is something that we're going to have to probably continue to develop and live with over the next year, and is going to form part of how we sort of address some of these challenges, by looking actually at who are we accepting, what are the services that we're running, and what do we have to start to make some decisions around in order to be able to try and improve that position.
Right.
Thank you. Are there any final, Teresa and John, did you want to make some?
Please, just to Joe's point about care plans, risk
Oh,
assessment.
sorry, I've chaired that very badly. Go on, come in. I'm jumping around too much, and I apologise. Go on, Teresa.
It's okay. So I just wanted to address Joe's point about care plans, risk assessments and supervision, and specifically the performance. So through the QPR process, we are requiring trajectories for improvement from the current CDSs. Those trajectories we are expecting in our August meeting in a few weeks' time, and very much encouraging CDSs to use QI methodology to find solutions to those long-term problems.
So, Chair, if I may, just picking up both that point and Usman's point, if workforce is such a major challenge for us, then surely there's a straight line between poor supervision or lack of supervision and retention of people. So they are urgent. And if it's gone on for 2 years, and in fact, in all the time I've been a NED, it's longer than that, then it's moved from urgent to, I'm not going to say it on a recording, but we really do need to get on the case. And if the divisionals are not understanding the equation, then we have a significant issue. I'll stop there. Thank you.
John, are you?
Chair, I was just going to come back on some of the previous points as well to add a bit more flavour. So just to Joe's original point around how are we keeping people safe. So whilst we've all given some practical examples that are based on specific services, I think the other thing I wanted to mention is around the process of clinical harm reviews that we've been establishing. I know we've discussed that through here before, but really getting an understanding of the impact of people who are on a waiting list, and again, very specific to individual services. Teresa's just mentioned it. I was going to reiterate the process around recovery performance plans that we're putting in place and that have been developed through Q1 of this year, which will have a focus on all the metrics that Joe's already described. Those are being signed off this month, and we'll be going through our QPR process. And then I think the final point, Chair, particularly around the workforce versus capacity equation, which then impacts on Joe's point around the impact on staff and retention. It's thinking not so much in terms of the practical recovery plans and the individual actions, it's more about the impact of transformation and different models of care. I know they are slightly longer term impacts, but different models of care, refining the number of people who come into specialist services, being able to offer people something sooner and a different way, I think will have the long-term impact on the caseload, the retention issues, the safety issues, the clinical offer, which will all impact on some of our performance metrics, both from a numbers and from a quality perspective. I just didn't want to lose the link with long-term transformation. I suppose that's the point I'm making.
Yeah. Okay. I said I would allow myself one quick question, if I may. I mean, forgive me. It is a little bit like the whole time I've been in the trust, physical health checks has been an issue. We benchmark very poorly again on physical health checks. I'm sure that no one in the past told me this had been sorted, but I was led to believe that this had significantly improved. And yet, when we look at the benchmarking, this seems to have gone down again, and I just don't know whether this is something that really matters, but it does feel like it has deteriorated, and we were told this was a very significant issue.
Fair. If I haven't got the specifics on it. I think I just wanted to highlight that on the physical health checks as we've currently reported it, that is at ICB level that we're reporting it at the moment, because it's not, that isn't an individual
it's not us.
number. So this is sort of
my apologies.
No.
Apologies.
So there are two targets that sort of sit in the mental health domain, but actually are only able to be recorded at Sussex-wide level. So by and large, it requires, I think it's the GP practices, EPRs, and the data from various other providers. And so we report this a bit in delay based on those. I'm happy to take away an action to find out what our specific numbers are.
It's
on
fine.
it.
It's fine. Yeah. I misunderstood what the information was telling me. And it was based on a previous conversation. Okay.
Peter, sorry.
Yes.
Just on that point, yes, it is a system target, but we are the leads for mental health in the system. And there's something for us about our advocacy as a board in the system about ensuring that KPI for the system is driven and is really strong. And we're taking that through the mental health learning disability and autism boards that Colin supports me with, and I chair. I just thought it's important to note that here, though it's not an internal target, I think we have influence and agency in that space.
Okay. Well, perhaps you could let them know that your board was asking about this. Okay, so I mean, I think thank you. I think my apologies. I slightly lost the sequencing of that, but I think we got there. So I think we note the gradual reduction in agency spend. I think we need to recognise that that is a significant achievement, even if those gains are hard won, and we know it's coming. We're going to have to keep working at. I think we should notice that that is at least going in the right direction at the moment, and I want to acknowledge the work that must lie behind that. I think we do notice that the complaints response rate is improving, but it's not just the metric, it's the quality of the response, and we want to make sure we understand that. I think that then there's been a number of questions that board members have asked in terms of trying to make sure that we understand what's going on. I just wanted to pick up on the point, and Jane and Funmi and I have discussed this, that at the right point, I think we do need to look at the interrelationship between some of these key areas of concern for us and workforce, but I want to do it at the right point. So at the point at which we're ready to then talk about people and workforce and culture, I think we could then usefully weave some of these metrics into that conversation, because it's clearly something that does come up, but I want to make sure that we're having the most constructive conversation about that we can, and I'll continue to liaise with the chief exec and the chief people officer on when would be the right time to do that. If we could put a marker down that that's something we'd like to look at, I think that would be helpful. Usman, I have learned the hard way never to fiddle with an integrated performance report unnecessarily. I think we don't want to keep changing it. We want to use it. I think I would encourage you to work on the insight section so that we're getting as much understanding of what the key areas of concern are. Are they do we believe they are successfully mitigated or not? And if not, what are our options as a board in terms of shifting the dial on the key areas of concern? And I think that's where I would want to focus our attention. So we're constantly thinking about, are we analysing this in the right way? And as we've requested, can we also then make sure that we're checking that something isn't I've lost my language, so that something isn't a special cause concern through an equity lens or an equality lens, even if the average might make it look okay. Is that all right, everyone? Thank you very much. That was helpful. Can I now move to Finance and Investment Committee report, please?
Thanks, Chair. I will take the report as read. We discussed a couple of things. Number one being the Lindridge divestment, which is going to proceed as planned, given the quality issues as well as the financial issues at stake. We discussed the finance report, which I'm going to not discuss right now and give Usman his time in the next slot to cover the recovery plan. We looked at the external audit benchmarking report from KPMG. One of the things we did discuss, and I believe that came up at the audit committee as well, that the benchmarking didn't really give us a benchmark, so it didn't really tell us what good looks like or what bad looks like. It told us where we were, high or low, but it would be great to see what does best in class look like. So we, what are we aiming towards, or what's a good target? So that is something we discussed, and I believe that I think Joe also discussed the same in the audit committee. And we approved the 3-year procurement strategy for Microsoft 365, given that we do run out of our existing capabilities by October 2025. That's about it from the F&I committee.
Okay. Thank you very much. Are there any questions for the Chair of the Finance Investment Committee? It's good to see a solution for Lindridge. It's been around for a while.
Yeah.
Good. Usman, was there anything you wanted to follow up on?
I was just going to go through and give a sort of summary of the year-to-date position, draw out a couple of key highlights, but other than that, if you're happy, I'll just do that, Chair, and then I would rather than go through the whole detailed report.
Okay, thank you.
So just colleagues will have got the papers, but just to summarise, at the end of June 23, Trust reported an actual deficit of £4.3 million, which represented an overspend against plan of 1.8 million. So we had always assumed that we would have a level of deficit going into the first quarter. Clearly, £1.8 million of plan is not ideal, and I think there are good reasons for it. So £500,000 of that variance is driven by unfunded national pay awards. I will be careful how I say this, but there has historically always been a gap between what the actual pay award costs us and what we get funded for it. Having worked through it, the team have calculated it to be approximately £2 million for the year for us, which should work out as the £500,000 that's then in quarter one. We are continuing to work with national and system partners just to understand in absolute detail whether there is any other mitigation to that and whether there were any other anticipated funding sources. But at the moment, it does appear that there will be an impact from that pay award of £2 million to us, and £500,000 of the 1.8 million variance in quarter one driven by that. I think it's worth highlighting that another £500,000, circa £500,000 of the overspend in quarter one is driven by national inflationary pressures that are over and above what we had received funding for, in particular in our utilities and in food inflation, in terms of meals we provide. So again, we think the full year impact of that at the moment looks like it will be 2 million. Now, clearly, there is more variability to that one because we don't yet know what all the prices necessarily were going to be tied into for the rest of the year. But as it stands, that will be a significant driver of unplanned overspend. The third key component of the year-to-date overspend then is the independent sector bed usage, which for the first 2 months of the year, while significantly reduced on last year, was over what we had targeted. But I'm happy to report that towards the end of June and into July, we have been on target. So we don't anticipate that overspend continuing for the rest of the year. Just to highlight some specifics then, we've talked quite a lot about our agency spend over the last few months and what we need to do around it. And clearly there are multiple components to that, focusing just on agency in the absence of looking at permanent recruitment, looking at pension, supervision would be unhelpful. So there are multiple work streams. The one I think it's fair to say that we implemented quickly and focused on in terms of just getting immediate grip and control was around approvals, who can use it, how they go through that process. And in month 3, so in the month of June specifically, we saw a reduction of almost £400,000 on the nursing and HCA spend. So I think that's frankly a pretty incredible achievement from where we have previously been, and a testament to the hard work that has been put in across a number of people, including lots of execs on this call who chair panel calls every day. And part of that process has been about tech and challenge, and part of that process has been about supporting divisional teams to understand what other alternatives might look like. Clearly, just having a controls process isn't the answer long term. So this work has been going hand in hand with work around recruitment and the incentives packages that we will offer. Funmi and I have been working really closely with our relevant teams to make sure that we're accelerating that work, and I'm hopeful at the end of this month we'll be able to begin to go live area by area, sort of team by team, with a very bespoke set of these are the incentives that we need to start advertising and getting out there in terms of getting people attracted to work here. We've also been doing a lot of work with the agencies themselves, recognizing where we are compared to others. I think we've had to take more direct sort of involvement in that process in terms of that market management. So I and Paula have been meeting with, frankly, all our primary agency suppliers, and we'll continue to do over August, so that we're really working with them, moving to hopefully a system where we have some preferred providers who work within the rates that we are able to afford, and more importantly, offer the quality in terms of the staff that we get. Because I think one of the big successes that we had last year didn't have financial benefit, but one of the really big successes is that off-framework agency usage and improving the quality of the staff that we did get and their compliance. So that's the work that we've done around agencies. I will sort of not dwell on the rest of the report in huge amounts. I think it's worth highlighting that earlier on in the year, we had seen some significant drugs overspends. Following further investigation, I said last month that or at the last board, that we would needed to understand that in detail. And I think we've understood that to have been a series of one-off charges related to last year, rather than necessarily reflective of permanent increase, but we'll continue to monitor it. From a financial recovery perspective, then, just briefly at the end, in June, we delivered £1.16 million worth of actual savings. So that was about 75% of the target for the month, and brings our total amount of savings for the first quarter to £3 million. And I know that is not where we would want to be, because we should really have delivered an extra £1 million of savings, but £3 million, 75% delivery year to date of actual savings, is more than we did in the last year. And I think demonstrates a very significant change in how the organisation has gone about sort of trying to put some discipline, put some creativity even to the ideas for how we reduce the amount of money we spend, and think about the way we deliver services. And sort of to the point that John and others have made through the course of this meeting around the work that needs to happen around transformation, and how we live within what we have. So I will stop there, Chair. I think everything else, I think, hopefully is set out clearly in the report, but I'm happy to take questions from colleagues.
Okay, thank you. Funmi, did you want to add to what Usman had said?
I did. Thank you, Chair. Just wanted to comment on the point Usman made around agency workers and our spend in that area, but just to then bring in some linkage to the overall impact on our substantive workforce over time. So, you know, the pressures around staff being stretched, not feeling supported. So in terms of seeing the impact on that, on freedom to speak up, and we will hear from Jackie shortly. And I just wanted to say that the piece, the work that Usman spoke about around the conversion plan does have all that in mind. And one of the things we are trying to do, which is to take what will be considered by many as a radical approach approach to recruitment and to retention. And this is in recognition, and I'm saying this to you as a board, so that you do feel not just only a part of this, but a part of the narrative. And the narrative is that we need to make working for us affordable for our people, and we need to make working for us realistic and reasonable. And what that means is that if we come across on blockers in areas that are considered difficult to recruit into or challenging, we will be looking at, on the face of it, that we are spending this money anyway in agency without necessarily giving us the assurance around quality and safety. So we will then start looking at some sharp and short decisions to incentivize our people to come and work for us, to incentivize our workforce to be supportive of that decision. And I'm very confident, to the point that was made earlier, Peter, around the tie-in to all those other things around complaints and sickness, we will then begin to see an uptick across the board on all of that. And I just thought it was really important to mention that so we can have that minuted.
Yeah.
Thank you, Chair.
What would an example be, Funmi?
Am I allowed to share a few examples, Usman? Yes. So a few examples without mentioning numbers, and that's why I wanted to just quickly check with the CFO.
Oh yeah, I'm not. Yeah, I just want to get a bit of a flavour, really.
Just to put it in context. So I think an example would be, we have 1,200 registered mental health nurses on our staff bank. So our staff bank is our temporary staffing scheme. Yep. We have less than a 20% uptake in terms of utilization. And that's because a significant majority, when the shifts are pushed out and released, and I'm going into some detail here, but it just helps to put it in context for us. When the shifts are released, people don't take up the shifts because, you're probably a band 7 worker and a shift has gone out for a band 6. Our policy as an organization is we pay you for the shifts that we need. What that then means is we have a significant majority of people who are available, who can do the work, but who wouldn't, because we would only pay them at a band 5 or a band 6. So we then have to go out to get an agency and potentially pay 5 times that amount we would have paid if we had paid you at your level. And other trusts practice, have a practice where we pay you your worth and we recognize your worth when you have to take on shifts. So part of the thinking that, and I call it radical, that Usman's, we've been sort of doing round robins around, is to say, can we come up with a scheme where if we're asking you as a member of staff to take on a shift, we'll pay you at your current rate. So we're not going over the moon and throwing money at people, but we'll pay you your worth. And what that means is suddenly, I say suddenly, but naturally we will get an uptake, because then we have our own people taking on shifts within our organization. Does
that's
that
a really helpful yeah. And I just, when words can become a little jargonistic if we're not careful. So when you talk about flexibility, I just wanted to get a feel for what kind of flexibility we're talking about, and that makes perfect sense to me. But I won't go any further, because otherwise the chief finance officer will get us both into trouble, which we don't.
Well, he is a champion. He's a champion of this, actually. So yes,
good,
we're in good hands.
Good. Okay, thanks very much for me. That was helpful. Dan.
I just wanted to mention a further strand to our work on this front, which Funmi and I are jointly leading on, which is our employee value proposition. How do we authentically market ourselves as an employer? What can we offer people to encourage them to come and join us? And importantly, that's insight led. So it's based on feedback we've had from something like 14,000 of our staff via a survey and focus group work, and we're looking to finalize that this month.
That would be fantastic. Good, thank you. Anna.
I just wanted to come in on Funmi's example and say that is absolutely, the right way to go. In my view, I think it's a common sense approach. I think it's financially sound, but even more important, it's about valuing people. And I think if we can start to create more of those sorts of innovations, then people will begin to get a sense that things are really shifting in a different direction. Because I think what you've done brilliantly as an exec team is get people to a point of recognizing intellectually that the agency issue is a problem that we all want to solve, but actually then getting from that intellectual kind of point to actually feeling that they at the kind of local level can do something about it. That also needs help from the team to say, well, here are some examples of what we think can be done. So I think it's incredibly exciting, and I think it's something we've wrestled with for a long time, and often the way with these sorts of issues, we're only just getting to the sort of the peak of being able to see down the other side. And I think that's fantastic, and just wanted to endorse and congratulate you on this work.
Okay. Thank you, Anna. Kevin.
I feel like shouting more. And that's what I want to come on to. Yeah, really good, and it was good to have some time with Fumi yesterday to kind of talk through kind of ideas and other things we could do to improve. There's something for me here about the kind of thinking that we're applying to these issues, and there are some key things within the organization that are so urgent and so important that we have to have a different way of thinking. We have to be disruptive, and we have to really think outside our usual thought lines, if you like. And there are 2 or 3 examples where we discussed yesterday, almost not quite wartime decision making, but definitely a different way of thinking, and approaches I've used in the past have been helpful. Have been things like a yes charter for things that we really need to do, looking at the decision making itself, defensible decision making, and I think it's a really good example of what we could apply elsewhere. It's transferable, if you like, and it's not that one example, it's the thinking behind it, if you like. And I'm so heartened that we've got such a new and growing executive team that can do this, and can really start supporting each other and making disruptive and decisions proportionate to the areas of risk, if you like. So thank you for the example, but also for the team that is working through this.
Thanks, Kevin. Teresa.
Thank you. So just really important to note the quality impact of the example that Fumi has just given. So we've got significantly less spend, and we've got substantive, highly experienced staff coming into those spaces being paid their worth. So the impact on the patient and quality, safety, experience and effectiveness is high, isn't it? Thank you.
Excellent. Well, Mimi, we've made several references to the meeting, to workforce and people. When would you like us to schedule some board time to talk about this? I don't want to do it, I don't want to do it too prematurely, but nor do I want to leave it, because it just feels like, because it's so, we're a people organization. It's so key.
Thank you, Chair. Next one. Yes, the next one's good.
Okay.
And yes, the next one's good. We have a people and culture plan that is going to be detailing all our actions and activities from now until April of 2025. I have made a promise to bring that to the ICB provider assurance. So it makes sense for us to be able to spend some time on picking what that looks like across the key functions around recruitment, retention, and training and supporting of our workforce and the attraction. Well, I call it the refining, and the refining is, so what Kevin was referring to around the wartime real-time decisions. And I was talking him through, there's some systems that we need to break down, and recognizing that some things do not serve us or do not serve where we are in the immediate term. I think there's a piece of work around that as well. So I want to see that reflected in the plan so that organizationally we're all clear on the messaging and we all know here are the 3 focus areas and this is what it looks like if we're doing well in those areas. So happy for that to be next board session.
Brilliant. Thank you very much.
Thank you, Chair.
Anything else? I know I've got an approval to seek on the finance and investment committee in terms of reference, but is there anything else on the finance report before I do that? No? Okay. So, I mean, we knew this was going to be a challenging year, but good to see, you know, reasonable progress through and some of those kind of key long-standing issues starting to be resolved, such as Lindridge and some of those is good to see. Can I just ask the board for approval of the Financial Investment Committee terms of reference for the next 12 months? Those are approved. Thank you very much. So thank you, Nitin, and thank you everyone, and Usman and everyone else who contributed to that. Can we move to the Audit Committee report, please?
Thank you, Chair. I'll take the report as read. Are there any questions or comments? Stunned you all into silence. That's amazing. Okay, so you have before you our annual report and the Audit Committee's terms of reference as well, which are here for your board's approval. So, Chair,
are we happy to approve those?
Thank you.
Thank you. Approved. Is there anything else on the Audit Committee report? Dinesh?
Oh.
No, it's just in your report, you talk about sort of quality assurance and of good practice. So one of the things that maybe at some point, maybe not today, we need to think about how do we use those examples of good practice in rest of the trust. And, you know, bearing in mind what discussion we'd been having earlier. So it just, I want to sort of put it out there.
Thank you. And it's something, in fact, Anna, Kevin and I have been discussing quite a lot in the last 6 months or so. So absolutely. And when we start to move forward on that, we'll be happy to have further discussion with you and others.
That'd be good.
Thanks.
Fantastic. Thank you very much. Okay, so thank you, Joe, for the Audit Committee report. Can we now move to the board assurance framework?
Peter, I'm sorry.
Yes.
Do we need to approve the Audit Committee terms of reference?
Yeah. I think that would be good.
Thank you.
Yeah. So can we please approve the Audit Committee terms of reference for the next 12 months?
Oh, I thought I was going to get away with doing it for another year. Thank you. Fine.
Thank you very much. So board assurance framework. So we've talked, I think we talk about risk in different ways in different parts of the meeting, and I think we're getting more consistent, but we still seem to talk about risk in slightly different ways. And I suppose the board assurance framework does provide an opportunity to pull that together and make sure that we've actually have got the risks properly identified. And that's important because actually then that's what drives some of the actions. And so I do think it's quite important, particularly at this, well, it's important all the way through the year, but particularly as we sort of come up to the halfway point of the year, just to check that we do think this is right and that there aren't things missing or there aren't things that actually are not being properly articulated, because this is what sets the flight plan for the board. And I just want to make sure that we do look at it properly and satisfy ourselves that this does capture the key strategic risks. And so I just welcome people just taking a moment to really ask themselves, does it do that at this stage? Because it does need to be a dynamic dynamic document. And I know we do change it from time to time, but it does need to be dynamic. Joe.
Thank you. At the last audit committee meeting, and I believe the one previous to that, we were actually discussing audit and risk. And there's been ongoing discussion in relation to the audit committee's focus on risk. But I think at the last meeting, with some input from the internal auditor, and Usman do come in, where we seem to be moving towards is that we, in terms of the business assurance, let's call it the business of board assurance framework, we need to pinpoint risk in a strategic way, which enables us to be able to track and monitor and to take appropriate action. And yet it feels really slippery. And I still don't feel that, from all the discussions that I have with others and with the internal auditor, that we have got a clear grip on it. I think what we have in the papers today is very process, and it's how do we move it from being, because I think we went through this learning curve with the board assurance framework in terms of what is this trying to do? What do we need to be aware of? What do we need to track? What do we need to measure? And I still don't feel that we've quite got there. Usman, Kevin, sorry, Jeff, because they were part of that discussion.
And to augment what I think we were saying, I think we also heard, Joe, that that at a board level, at an exec level, that perhaps the risk calibration is right. But we heard that as we go down through the organisation, that risk calibration is less exact. And we saw some examples of quite out of date risks, actually, didn't we? And they were, and indeed, using the wrong framework to assess the risks, and some reference to no longer existing organisations. Like so there was a little bit of concern that up and through the organisation, and actually an acknowledgement from the exec that there had been slippage on more local risk ledgers. So I guess our concern was also how live and how dynamic and are we getting all the information we need to appraise the risk at frontline team, service and uppers level in order to be aware of that dynamic risk ledger. That was I think the other side of that concern, but challenge.
Yeah, that's helpful, Kevin. Usman, do you want me to go to Jane next, or do you want to come in?
I'm always defer to the boss. So
I thought that might be the answer, but I thought I'd let you do it, Jane.
I'll only take up that because it's in response to Kevin. I think, and I think it's important to demonstrate to the board that you will see that some of the risk profile in the BAF is significantly different this time.
Yeah.
So the risks around quality, in particular safety, have gone up significantly in light of the issues that we have identified in Chalk Hill and the assurance we've had as a result of that. I would hope that in the next few months, as we go through that improvement plan, that risk will come down. But I thought it was useful to actually give an example.
Yes, of it being dynamic.
Yeah.
Yeah. I'm going to go to Teresa because I'm guessing you're coming in off the back of that.
Thank you. In part, I am. I think there's to answer a question that you asked at the beginning, which is, does this cover everything? I would be keen that we were to further explore where demand and capacity sits and whether that itself is a BAF risk.
Yeah.
We also had a good conversation if in the finance an improvement committee. Simon, you're nodding. Around number 9 specifically, and it took us to a conversation around, have we got the risk descriptions correct?
Yeah.
And which sub-board committees are overseeing which risks? Because I would say that, and just number 9 as an example, given how I was interpreting number 9, that's a significant quality risk, but we're not taking that risk through QC. We're taking it through F&I.
So
I think there's some more work for us to do as a board to assure ourselves that the risk descriptions are exactly as we need them to be, that they're going through the right subcommittees, and how are they shared across the other subcommittees, because these aren't black and white. and often they do dovetail into other committees.
They do. And that's a nice example, because actually we talked about rises. Quite often we talk about it through the lens of financial sustainability. I'm being careful with my language. We less often talk about it in terms of the therapeutic nature of the environment that we're creating.
Mm-hmm.
And yet both are key, both are significant risks. I mean, they may not be strategic risks, but they're both significant risks, aren't they? I mean, we can do that one of two ways. I mean, I think you're absolutely right. It does then speak to risk identification, but actually I don't personally have a problem with the same risk being delegated to two committees, as long as there's a conversation between the two committees about what they're each looking at. But you're right, we can, you know what I mean, we can triangulate, we can create that triangle. That's really a really nice example, actually. Thank you. Usman, you've been very patient with me, so I let you come back.
Okay. So I think a lot of the points have been covered. I think it is worth highlighting in the cover page on slides, page 6, that we do set out the 5 risks where the score has changed and has got higher in effect. I think it is important to recognize that we are using this as a live document and that we are constantly challenging ourselves to say, is that reflected within the board? I think to Kevin's point, there has been a question about, is the same approach that we're taking with the board assurance framework applied all the way through the organization? But I think we have agreed, but for a good reason, that rather than necessarily dwell on exactly how we got here, given that we're moving to new divisional structures, is how do we ensure those new divisional structures have risk management and the same risk management approach at the heart of them, and then that flows through. And so I think that's what we've been, as part of the development work with them through the QPRs, have been doing. In terms of BAF risk 9, I think it's just worth specifically saying, so I think one of the key points around that, what that FIC discussed, was actually at a point in time, we, like some of the NHS, kind of just badge digital and estates in the same bucket as infrastructure, and that they're actually two very separate things.
Yes.
And so I think we've said that during the course of the second quarter, as part of our quarterly review of those risks, we would likely be seeking to recommend creating a new risk that separates out estates infrastructure from digital infrastructure, and then per Teresa's comment, decide where it goes. So I think it's just worth sort of highlighting those specific points, both in terms of the quality risks that have changed, and then BAF risk 9 around infrastructure, and then BAF risk 12 relating to the deficit, which has also shifted, but in a positive way, because I think the work that we have been doing, and I don't want to jinx this, but the work we have been doing, I think, means that we can say that while it still remains a significant risk, it's perhaps not a 20 score as it was previously listed. So again, just to demonstrate that we're not just looking at the BAF and saying everything has to be a 20 and a red, but actually realistically, where do things sit and what genuinely is the consequences of those things. And then we will, as ever, do the update work during Q2, and it will come as part of the October board report.
Okay. Kevin, were you wanting to come back, or was that a legacy?
It's fine. It's good.
Okay. So I wonder, Usman, if then what we need. So I think we note the fact that actually this is dynamic. We are changing the risk scores, and I think that's really important. We need to then think about, so what does that mean in terms of then the way in which we then prioritize our time and use our time? Yes, Kevin.
I wasn't sure, and I'll say, okay. The point I was making about kind of the bottom up board to floor risk assessment and risk management system, if you like, I think what wasn't quite captured in the response I heard. So I just want to, if it's okay, just ask a bit further, that I think where we need to get to is that 99% of the risk of this organization is held to the front line, and we want to make sure that that dynamic assessment of risk comes up and through, and that if there are lags and time lags, that we at least that dynamic assessment risk, we know it is a lag. And I wasn't quite sure I was hearing that in either response, if you like.
Okay.
So, but
I will do my best to pick that up in my summary. Okay. So I think we are reassured that this is a dynamic document, that because we can see changes to it. I think that we need to make sure that when we do that actually has a consequence, and we understand what the action is that comes from that increased level. I think we are just asking some questions about the way in which operational risk travels up the organization, and then the way corporate risk is then introduced in order to then identify what the strategic risks are, because we need to make sure that they're traveling up and down as well as across. I think there's then a question about risk identification and risk allocation. So we're going to explore the need to create something on demand and capacity. I think there was a really good point around 9, around whether we need to recognize, one, that there may be a risk around digital transformation and estates transformation, and that may then need delegating both to finance investment and quality. I don't mind how we do that, whether we create an additional risk or whether we delegate the same risk to 2 committees but with different purposes. I don't think that bit matters. It's more that actually we know what is happening and what their responsibilities are. I also think that perhaps when we allocate the risks to committees and groups, we might just ask them to have a conversation about whether they think it's properly identified or not. That actually it could be more of a two-way process, because I think that would help. And I suspect that when we then say, for example, talk about people on the 13th of September, it would be good to have then brought the people BAF risks, and then we can make sure that we're just reviewing those. So whenever there's an opportunity to do so, that we're reviewing them and keeping them live. Is that all right for today? And Simon?
I would just say, Peter, I would be worried about us splitting a risk in terms of accountability. If there are 2 parts to a risk, I think it is fine. I think there's just something about being really, really clear. If two groups have got accountability for one thing, there is a risk that the other group thinks somebody else is doing it. So if there are 2 parts to one risk, I think it's fine to split accountability. I would be nervous about splitting accountability for one risk across 2 groups.
Okay, so what I thought I was saying was it's okay to delegate the same risk, provided you're clear what each group is being asked to look at.
Okay.
Are you saying that you'd be worried about that, and actually you'd rather we created 2 separate risks?
Yes.
Fine. Okay, that's fine. Joe.
But in fact, Simon, just based on the experience of some of the risks that sit with Audit Committee and Quality Committee, and we share what we're looking at with each other, but applying different lenses to the same risk, it actually works well. So it's coherent. I take your point, but
but let's keep the point. Let's keep the point live through the conversation, and then we can work out what the best way is to respond is. Okay, thank you very much. Is there anything else on the board assurance framework? Okay, thank you very much. So, Jackie, hello.
Hi, can you hear me okay?
We can hear you, lovely.
Thank you.
So you're going to present your Freedom to Speak Up Guardians report for this period, aren't you?
Yes, thank you, Chair. I present twice a year to the board, twice a year to the executive committee, so every 3 months. So I'm going to take the report as read on this occasion, but I'm obviously happy to take any questions. But I did want to highlight 3.1, 3.2 and 3.3, which is where I'm asking the board to make some decisions around some of the challenges I face. So are there any questions on the report before we get to that area?
No.
Lovely. Great. So one of the feedbacks of the 2 that are listed talks about someone feeling quite dissatisfied with their experience of speaking up. And obviously there's only 1 out of 6 saying that, but I think there's something about listening to the silent voices. A lot of people don't feedback their experience of speaking up, so we don't know what they think, and a minority are saying it's not working. So there's something about, we know the numbers are high in terms of speaking up to me, and they remain high. So there's something quite consistent about that with our promotion and sort of expansion of Freedom to Speak Up over the last couple of years. But there is something about now the quality of those responses. Do staff feel that they are heard? We're not here to fix it. That's not the Speak Up motto. It's speak up, listen up, follow up. Do staff feel we're following up? Would staff speak up again? Do staff feel heard? And all this links to retention and all those good things that we want in the work. So I was hoping that we could start to establish some boundaries around the response times. So there's no national requirement on this, but there is a requirement that there should be a response time that we decide, but at the moment there really isn't one. And one of the problems I have working on my own predominantly is that if speak ups go out to people and I don't hear back, I have limited chance to chase all those things up when I'm dealing with new people. So I wondered if the board were happy to support the suggestion there that people respond within a couple of days to acknowledge a concern, and that services follow up within a month if that's practicable. Jane, sorry, Chair.
Sorry, Jane, I was on mute.
I couldn't find it. I was putting my hand up in person by mistake. I wasn't thinking. I think that's a really helpful suggestion, Jackie. I wonder whether the board is the right place to take that question, and whether that needs to go to the People and Culture Committee for a recommendation to Exec Committee, and then we report it through to the board. I think what's important, the processes around freedom to speak up, I think sit with, for me as the executive lead and through the People and Culture Committee. And I think for the board, we need to hear the themes and the whispers in the wind and make sure that understand where the challenges are. I don't know your thoughts, Peter.
I think that would be more helpful, and then anything that needs escalating can be escalated from that.
Okay, that's fine. And is that the case for 3.3 as well, about where FTSE sits? Sounds like it's a similar thing.
Yeah, I think so. I think you'll get it means you can get a rapid response when you need one.
Yes. Okay.
Otherwise, the risk is we created. You're trying to speed up, then we create another delay.
That's fine, no problem. Okay, I will take that to the next committee. Is there any other questions today?
Anna has her hand up. So.
Okay.
So just to backtrack slightly. So I mean, I can see in terms of operational reporting, that all makes sense. But I think I would just like to check out whether actually we do support responding to speaking up concerns in a timely way, because I think Jackie does need that from us as the board. That principle, exactly how it's done, and the reporting up, I agree. But is that a given?
I think it's the nuances of what that means, because it has implications for other services and other deadlines they have and all sorts of things. I think the principle of having a deadline is fine. What that deadline is and how it fits with the reporting structures,
okay,
we need to get in place first before we agree it.
That's fair enough, Jane. I'm aware services are very busy, and I do think some of the delays linked to that. There are lots of other national structures that are like complaints from patients that require a much more specific, timely response. But the danger then is speaking up falls off the list because it doesn't have its own boundaries. So I think that's why I'm trying to raise it. But I hear that people would like that to go through PCC with more thought.
Well, I think Anna's. The point we're trying to say is that the board supports the timeliness of the need for a timely response, and we would then expect that to be delivered through the chief exec and the People and Culture Committee. And you should feel that you can alert us if for some reason that's not happening. But I don't want us to become the place where you bring things, because actually that will cause more of a delay, because we only meet every 2 months. That's what I'm trying to say. So I think we're very supportive of what you're trying to achieve. We're just trying to make sure we've got the right way of achieving it, but there's still the accountability back to us because you have direct line of sight to us if you feel that's not working. And I'm confident that we will sort this out, but nonetheless, you have that backstop. Is that right, Anna? Is that?
Yes, no, I think that's exactly what I was looking for. I just think, yeah. So if that's noted, that we are supporting your request, but we are leaving it to the exec to work out exactly how that can be be put into practice along with other you know, operational challenges. I accept that they're there and they have to be taken into consideration. But yes.
Is that better, Jackie? Does that feel like a okay, good. Teresa, sorry, Tracy.
Thank you. It's all right. Without wanting to reiterate the points that have been made, I completely agree that there is a process through the People and Culture Committee that we need to take this. That's great. And Jackie's caution around the timeliness is a really important one. So I'm sat thinking of a couple of themes of freedom to speak up. One where we may have responded better and quicker, and this would help us to resolve that. And one where we have responded really quickly. And I have no doubt that the one that I'm thinking about will have had significant patient safety improvement as a result quickly. So it feels really important that we do that piece of work and that we get that agreement quite rapidly through the eyes of patient safety and of course our staff experience in how they're supported to deliver safe care.
Thanks, Teresa. I often feel that there is a lot going on in the background after speaking's up, but that's not always communicated. So my worry is that actually people are left just not knowing that there has been a response. And I think people can get quite demoralised.
Okay, that's helpful to know. Joe.
Thank you. Thank you, Jackie. Interesting report, and the themes that this time round are quite different from some of your earlier reports, particularly the first and the second bullet point. Can you just expand with some examples of under each of those headings? The first is in relation to patient safety concerns, newly qualified nursing staff. And then the third bullet point, ongoing issues around civility and inappropriate behaviours.
Yeah, so sometimes we get group speak ups. So we get several people speaking up from one service. So that might put this, because every person counts as a case under speaking up guidance. So if 3 or 4 people speak up from one team, it instantly goes to the top of the list, which is why it might show here in a way that it might not if it was spread over time. So that's about sort of new staff coming into services where there simply isn't enough staff and they therefore find themselves thrown in the deep end too soon. And that's their subjective experience. That may not be how other people view it, but that's what they've been feeding back. And it relates to a particular service that's already very much in under the guise of the exec. And the last one, I think, has been coming to the executive committee, may not be in this report to the board, but I think that overall we're seeing a rise in sort of poorer behaviour, conflict between staff at lots of different levels. I don't know if it's the pressure of the work, but I feel really since last October, there's been an increase in people calling about conflict between staff rather than patient safety. So it's definitely feeling like the strain is being felt within services and being acted out within them as well. I don't know if that helps you, Joe. It's a bit vague, but it's coming from lots of different places, I think, and it still is this quarter.
Oh, that's helpful insight. Thank you.
Thank you. Peter.
Thank you, Chair. I would just like to thank Jackie for the time she spent with me yesterday or the day before, where we, for about 45 minutes, really helped me understand the role of the FTSU Guardian here. And I'm mindful that my training will have rolled over from my previous organizations. So we're all undertaking training at the moment to bring ourselves up to the highest level. And I think that's incredibly valuable for new starters to understand the process by walking through the training and talking to Jackie. I've had a look at our policy just so that we all know how it works. I think the other piece, absolutely, the timelines around this, we need them. We need to go away and work on that and have them, because I can see that when a freedom to speak up comes to me, there may be a whole set of lines of inquiry that need to be followed, because often the concerns are multiple and relate maybe to service standards or to the way a person's been treated or managed. Bringing all of that together quickly within an agreed time envelope would be very useful. And then, Jackie, I think I've come to appreciate just how important it is that you have some personal sense of closure on where we are with our proceedings, because I could see that either you're unsighted as to whether we feel the job has been done, or we think the job has been done, and you might have a relationship with the person who's spoken up and they might say, actually, no, the job wasn't done. The job wasn't done to my satisfaction. I've been left feeling further bruised by this, or less likely to speak up in the future. So thank you for the work. And also, I was quite surprised at how vulnerable the role of guardian is, and how isolated you might be in terms of the uniqueness of what you're doing. So I think some of your comments in your paper about how you feel you might be better placed in the organization, I took that quite importantly. Thank you.
Thanks, Peter. Is there anything else for Jackie?
So,
Jackie, is there anything else you want? Sorry, yes, of course, Anna. Sorry.
Sorry, I'm really encouraged to hear you say that, Peter, because that's exactly my sense. And I just want again thank Jackie for the really hard work this is, and really important work to us as a trust. So I think we need to take this incredibly seriously, the issues that you've raised. I suppose the thing I just wanted to add really is the sense that if we don't, then it undermines the authenticity of the process, and that absolutely mustn't happen. Because if people begin to think and begin to socialize the narrative that, well, there's not a lot of point, because nothing's going to change, that's fundamentally something we need to invest resource in stopping, I think, and take it very seriously. So thank you, Jackie, for all that you do. It's hard work. It's hard work.
And I agree, if speaking up doesn't work inside the trust, people will just go outside the trust. They'll go to the CQC, they'll go elsewhere.
Yes, exactly.
And that's not necessary if we know.
Thank you. Kevin.
Jackie, thanks from me too. And I'm wondering if what we're saying is we need something a bit more precise about what the board wants to be doing next with this. And I wonder if we need to capture really carefully what we mean by timeless, what we mean by triangulation that Peter was talking about with other areas, and early warning systems, just to make sure that we are tying things up. So it's great that the executive are going to go in and figure out how to knit things together, but I think we possibly as a board need to be precise about what we mean.
Yeah. So I think, thank you. I think that obviously, I think you're absolutely right. The freedom to speak up is really important to us, and it needs to work. And we recognize that this is really important work, and we want you to feel that you've always got a direct line of sight to us. I think that you're certainly listening to what you're saying, that I think we will ask Jane to go away with the executive team just to think through actually some of the issues in terms of actually how do we make sure we're removing any barriers to resolution. We've got the right processes in place, and we'll make sure that gets reported back to us. But clearly, things like where freedom to speak up sits, where you report to, clearly those are things that we leave to the executive to sort out. But we definitely want you to feel that we really appreciate what you do and the conflict resolution that you do, and we do recognize the importance of that. I think if this trend of there being, because people are under pressure, there is more conflict between staff, I think we may need a bit more granularity of data, and it would be perhaps you could talk to Funmi about how we make sure we get the right information so we understand whether there are any particular themes there that we need to be keeping an eye on. You know, these things can just be very situational and very individual, or there can be themes coming through that we need to be alert to. If it's okay with you, Jackie, I'm going to leave it there for today. You're talking to a group of quite tired people now, so I don't want to rush this, but nor do I want to leave it longer. But as we always say, you have a direct line of sight to the board, and you have a direct line of sight to me as well as to the chief executive, and we really appreciate you coming today. Thank you, Jackie.
Thanks,
okay.
Jackie.
Oh, sorry. Okay. Rather optimistically moved my agenda. Okay, so I think that brings us to the end of our formal business. Is there any other business? Okay, so can we end the live stream, please?